Welcome to the Phoenix Prosperity Podcast, where wealth meets legacy. Join your host, Tim Fergestad, as we explore the journeys of Phoenix's finest to success and beyond.
Hello, this is Tim Fergestad. Thank you for joining us. I'm very pleased to have Breck Rice with me here today. Breck is a healthcare disruptor, co-founder of ServRx, chairman of Brim Wellness, advisory board member at University of California, Irvine, adjunct professor, author, entrepreneur, and community pharmacy advocate. Absolute rock star. Welcome to the show, Breck.
Hey, thanks for having me, Tim.
So I imagine most of your time is focused on the ServRx company here in Phoenix. Is that right?
That is correct. Yeah, ServRx is a third-party claims processor, a third-party payer that we formed about 11, 12 years ago now.
Okay. And explain to people what that is and why that's important.
Yeah, so third-party claims processing, specifically our clients are community pharmacies that would have a patient walk in who has been, injured on the job and needing a prescription filled. Well, the workers' comp program is an entitlement program, so no one pre-enrolls into workers' comp. Now, the companies, the employers, carry a policy possibly, or they might be self-insured and paying for it out of their own coffers, but no individual actually, enrolls in workers' comp. You don't wake up one day and say, I think I'm going to get hurt on the job today. I better sign up for workers' comp. No, you only get enrolled after the injury occurs. And so when that does occur, there's a gap or a delay before, the carriers like Liberty Mutual, Travelers, Hartford, whoever would know that there's even an injury. But that patient still needs care that same day.
Sure. Yep.
If they've got an open wound, a cut, you can't wait around for 2 or 3 days to get verification that it was work related. They need their medication today, or they're going to get some infection or what have you. So we step in and fill that gap. ServRx steps in, takes care of the patient same day without any delays, no out-of-pocket expense to the patient, and allows the pharmacy to go ahead and dispense those medications that are needed. So we act as a default processor for that first report of injury or that first few days of the injury, but then we can continue to process the claim over the life of the claim for most self-insured employer groups. Only occasionally you would have a big PBM like an Optum RX or a Express Scripts or Caremark or CVS Health would also step in at some point and say, okay, that claimant is in our network because we manage their employer's workers' comp plan. So we help the pharmacy navigate that. And when it's a in-network claim, we let the pharmacy know, hey, you need to process that to Optum or Express Scripts or whoever the PBM is. But you're still a good portion of claims will fall out of network, and then we'll manage those for the life of the claim.
Okay, can you define PBM for our listeners, please?
Yeah, Pharmacy Benefit Manager. So they're a middleman that was formed back in the early 60s to kind of come in and help control costs and make sure that patients were getting the right medication for the right purpose in the workers' comp segment, which we operate in as a company, ServRx, doing specifically workers' comp. Those middlemen, those PBMs sit in there, and again, initially their job was to help control costs, and now today they're the number one reason why drug costs are going up. So,
are they the ones who dictate the formularies at different companies and such?
Absolutely, yeah. Yeah, and the formularies you would initially, again, let's go back to the 60s when they actually had a good purpose and were doing good by the industry of healthcare. They were helping to control that those medications would be the best medication on formulary for whatever the disease state is or the injury type. Today, those formularies are based on the rebates that they're getting, so it doesn't even have a lot of medical connection whatsoever.
Yeah.
It's all money driven today.
Okay. Yeah, the bean counters got into the the management side.
Well, private equity, they need to earn show a return to their investors, and you got to keep finding ways to do that creatively. And spread pricing is probably the biggest way that PBMs do that for community pharmacies today. They'll contract with the community pharmacy really, really low reimbursement so that the PBM can take a much bigger spread off of the actual processing of the claim. So in on the commercial side, healthcare claims or Medicare, Medicaid is a little different, but I can only speak to workers' comp. Every time a PBM's involved, they're probably pocketing about $50 to $60 on every transaction.
Okay, so brass tacks on ServRx over, or going with you. I mean, you can save 30-40% over having that middleman in the loop for a lot of those
Yeah, so
claims.
for the community pharmacy side, they're actually getting a fair reimbursement because we pass it on to them. We're not taking that spread in between. So we're passing that on to the community pharmacy and they're getting a fair reimbursement. On the self-insured employer side, if we're managing that or removing that middleman, then the same thing. We're passing on whatever that spread was that the middleman was taking, and the employer can save about 30% off their drug spend. If you look at the contracted rates that community pharmacy has to take today, it's really sad. 15, 20 years ago, the profit margins were 35, 36% for dispensing. Today, pharmacies are lucky to get 3 to 5%. So it's like
Wow.
grocery store margins, Tim, but without the
Yeah.
front end. So for an independent, a small, mom and pop pharmacy, it's hard for them to stay in business. And in fact, about 1/4 of all of the medications dispensed at a community pharmacy actually walk out the door below the acquisition cost of the drug. There's no amount of volume that can make up for that kind of loss,
No,
right?
no,
If you're
no.
losing, $3 on a script, you can't, fill 100 scripts and try to make that volume up. You're still losing $3 per script.
Right, right. Okay. So, let's talk a little bit about some examples of the people who are benefiting and some of the other aspects of the industry that can benefit from ServRx. You said self-insured employers. Can
Yep,
you give some
self-insured.
examples of how that works and how many of uh, people out of the marketplace are currently using or should be using?
Yeah, every self-insured employer should be using, ServRx to process their workers' comp and be a partner for a couple of reasons. We cut out that middleman that's upcharging and charging them, for things that they don't need, like bill review and all of these hidden costs. And even when PBMs or pharmacy benefit managers come in and say that they have a transparent program, they're still overcharging for those medications and pocketing that spread. So if you can remove that middleman out of there and work with someone like ServRx, then you do truly have a transparent program. I give you an example. There's a big hospital here in town, hospital system. They have, multiple hospitals and multiple clinics. They have pharmacies, and we were already a partner with them taking care of their pharmacies, so that if a patient was on workers' compensation, we were helping the pharmacy process those claims and get the fair reimbursement that they deserve. But now we also help them with their own employees. So if a nurse accidentally gets a needle stick, it's a pretty expensive drug therapy that they need to go on in order to protect them from, hepatitis and HIV and all the other diseases you can get from blood. We step in and now we just take care of it as a straight pass through. There's not even a markup on that. And I'd love to get the numbers on how many millions of dollars we save that hospital system per year just taking
Right,
care of their own employees.
right. Okay. That's a great example
Yeah.
of how you can do it fast and save money.
But we could do it for an employer that doesn't own pharmacies also. So it doesn't just have to be a self-insured employer group that happens to have pharmacies. We can do the same thing with, any Phoenix employer that's self-insured because we have partners that are pharmacies that they could use. We also have our own way of it's a concierge white glove service for employers to take care of those injured workers, and we can do that through our network of connections here in Phoenix.
Okay. Okay. So you're Phoenix based. Are you outside of the Arizona market though?
Yeah, we have pharmacies in all 50 states that we do the third-party billing
Okay.
program from. Some states are better than others for us to operate in because some states have either a monopoly. The payer is, like, I'll give you the example of Ohio, for instance. Ohio has the Ohio Bureau of Workers' Compensation, and they control about 98% of the lives in the state of Ohio. Washington State has the Washington Labor and Industry, Washington L&I. It's a monopoly. You have to go
Huh.
through that payer. California is rough for us to do business there because it's all these little closed networks, and we're 100% out of network. We don't have any affiliation with PBMs. We stay completely independent of the pharmacy benefit managers. That way, we can take care of our clients the best. But yeah, we there are states that we do better in. Than others, but we do operate in all 50 states and are contracted with, several thousand community pharmacies. At one time, it was about 20,000 that were contracted with us. Not all of them use us on a daily basis because not all of them have, workers' comp claims to process. So
Right.
maybe, only half of them are using this on a regular basis, but under contract is about 20,000 community
Okay.
pharmacies.
Okay. Nice. It's surprising that free markets aren't allowed in some of those areas. Is that what? Why would is it just trying to protect workers? I guess they're trying to pass legislation to make sure they're okay, which increases the cost for the employers.
Yeah, those monopoly states are, it's revenue for the state. So, the Washington L&I, they're generating revenue for the state through that program.
Huh.
Ohio, I'm sure it's similar that it's a revenue generator, but they're also, like you said, trying to control the cost. And if you have a PBM in there that is, working off a spread pricing, they're going to continue to drive up the costs.
Yikes. That's unfortunate. That's a problem and a half.
Yeah, yeah. It's everyone, from the patient side, they think that it's the pharmacy that's driving up the cost of the drug, and the poor pharmacy is caught in the middle of it. They're actually in worse shape than the patient on that whole scenario. And then you could also attack the pharmaceutical manufacturers too. Oh, they're driving up the cost. No, really the number one reason for the driving up of costs of medications today is actually those middlemen.
Okay. The pharmacy benefit managers.
Yep, correct.
Okay. And are those, I mean, I always like to tell people when they complain about healthcare to follow the money, and you can see who have the biggest buildings in all the cities, right? It's insurance companies.
Yep.
Um,
Yeah, there
uh,
was a time in my career, about 15, 16 years ago where I kind of had a little bit of a crossover in where, I was invited to those insurance meetings, risk and insurance and saw how the other half lived. And you're right, those conferences were, seafood towers and yachts and sailboats with a big, banner of the insurance company as the cell. And yeah, it was a little different lifestyle that those big insurance and PBMs were putting on a conference versus going to a,
wow.
a pretty humble community pharmacy conference.
Right, right. Okay. Yeah. And just the fact that some of these communities, or not the community pharmacies, but some of these metro areas are I don't know if they're turning an eye to it because it's also a revenue generator for the government. And is that why? Is that maybe the biggest driver for them to do it, or is it
I
really
think
trying to
it's
look out for
yeah.
the worker somehow?
I think it's relationships, and then it could be a little bit that
Okay.
that there is some benefit that that municipalities or government officials are getting. I mean, I really wish that any elected official would adopt kind of the NASCAR model, and would wear a jersey that would
Oh, right,
state
right,
who they're sponsored by. That would be a
right.
little easier to vote for
Yeah,
somebody if you knew that Pfizer
yeah.
was
Then
was sponsoring them, right? Or
right.
or a PBM like Optum was their big money donor. And unfortunately, as funny as that sounds, that happens all the time, right? We had
Mhm.
legislation passed right here in our own home state of Arizona that took the right away from doctors that doctors have had since Little House on the Prairie days. I may be dating myself here, Tim, but if anyone remembers that series, Little House on the
For
Prairie,
sure. The
when
Wilders.
yeah, yeah, exactly. When you needed the doctor, somebody had to ride into town, get the doctor, and bring him out to the house there. What did he have with him when he came in? He had his little
Yeah,
black bag, right?
yeah.
What did his little black bag have in it? It had the medications and stuff that he needed. So since the
Hmm.
beginning of time, physicians have had the opportunity to also dispense medications as well. Well, that right was taken away here in our own home state of Arizona by the PBMs. They legislated and legislated for years to get that right taken away. Why? Because those meds that were going directly to the patients were bypassing their networks and they weren't
Right,
getting their pound of flesh.
right, right. Okay, okay. So let's go back to this market. Are there any examples of sort of big self-insured companies that you can give an example of how it works?
Yeah, so I mean, for a big trucking company, like we have Knight Transportation here
Okay.
in
Yep.
town, or that would be a good example because they have drivers all over, or even PetSmart. They've got stores all over, and somebody working in a warehouse, falls off a step ladder or sprains their ankle or whatever, ends up needing a prescription for an anti-inflammatory or something like that. We would be able to step in and replace whatever that middleman is that they have today and just streamline the process. It's a cost plus model. So it's kind of like Mark Cuban's drug company that he has, Cost Plus, for
Okay.
generic medications. If you're familiar with that concept, you really actually know what the cost of the medication is. We would do the same thing in processing the claim for the employee at the warehouse at PetSmart, or the driver that couldn't wait for somebody to grab a hand truck, and so he went out there and tried to unload something on his own and strained his back, for night transportation. We could step in and process those claims for them at just cost plus.
Okay. Okay. Excellent. Excellent. What are some misconceptions maybe about the industry and or the services you provide?
Yeah, I think I'm not sure that there are any misconceptions about the third party billing side of things. There's certainly a lot of misconceptions about the PBM or the pharmacy benefit manager side, that somebody truly has a transparent program when it's not. There's extra fees and things that are added on just to generate more revenue for that PBM. Back to your point that you made, Tim, about just go and look where the biggest buildings are and what names are
Right.
on them, follow the money.
Mhm. Yep.
You've got a local PBM here in Arizona that was a little company that was acquired by a big pharmacy chain um, out of the east. And that pharmacy chain had 10,000 retail locations. They were selling anything and everything you could possibly think of. You could go there, not that you and I need it, but they sell a lot of hair products. They sell a lot of makeup. They sell a lot of chips, soda, anything you can think of. Oh, by the way, they do dispense some medications in the back too of the
Right.
chain. So
Yep.
10,000 locations, but yet 80% of their profit margin came from that little PBM up in Scottsdale off of Shea.
Huh.
The PBM that doesn't own the medication, doesn't dispense the medication, doesn't have the staff to operate the pharmacy. They're just the processor.
Right.
Was
They're
making
just those
80% of
margins.
their
Yeah.
80% of their profit, even though they had 10,000 retail locations. So a little bit of a racket if you follow the money.
Yeah. Wow. Okay. For sure. And So, why should people care, right? I mean, how much of their costs are being sent onto them? I mean, they're paying. It's part of their package, maybe through their employer or something, right? They're paying for it in some capacity.
Yeah. Yeah, unfortunately, the injured worker doesn't really care because they know they don't have a copay. It's an entitlement program, right? So it doesn't cost them anything to get their
Right,
medication. It's the employer who should care because the employer is literally paying 30% more for those medications than they need to. So that's why we start with the self-insured employer groups because it's their money. It's
right,
not that they're paying a policy and then they have a carrier that's covering it. Even if you have a reinsurer that is going to take over anything catastrophic, and you're going to only pay out of pocket for the first 50 or 100,000 or 250,000 or whatever your limit is, and then it's going to roll over to a big carrier to cover anything catastrophic. That's still that company's money. Why are you just going ahead and, every time you have an injured worker that goes in and fills a prescription, you might as well just go into your bank account, pull out $50, light it on fire. What employer would do that with any clear conscience, but they do it
right.
all day long by partnering with a pharmacy benefit manager.
Okay, okay. So, Breck, what are some of the bigger goals for you and or the company?
Yeah, I think the main thing is to expand our help into the self-insured employer market, especially here in Phoenix, since we're a local Phoenix-based company and have the ability to do that concierge service for employer groups right here in town. But the one area that I'm really interested in helping is our community pharmacies survive because of those poor reimbursements that community pharmacies are getting from the pharmacy benefit managers, the PBMs. A lot of them are going out of business. Now,
Hmm.
ServRx is partnered with every pharmacy service organization in the country. They manage the contracts for all of the independent pharmacies, and that's a real blessing that we have that relationship where they're preferred partner for third party billing. But the downside of that is that we also see all of the closures that are happening, and we're at
Okay.
one community pharmacy going out of business per day now. So
Whoa.
every day we lose a community pharmacy. So I've launched a full-on campaign to try to save the industry. I also host a couple of podcasts. One is the
Okay.
PBM Reform podcast on the Pharmacy Podcast Network, and then I do a Community Pharmacy More Profit Roundtable. And that More Profit Roundtable is specifically helping to bring in solutions that bypass the PBMs to help community
Right.
pharmacies. And one of the biggest areas of opportunity right now is a community pharmacy expanding their scope of services into clinical solutions. And there's a way for the community pharmacies to partner with the local doctors so that they're not taking the attribution away from the local doctors. They're actually supporting them. They're filling care gaps that the local providers don't have time to get to. So it really is a win-win-win. The patients
Right.
win because they have easier, more accessible access to go into a community pharmacy if they've got a scratchy throat or they don't know if it's a cold, allergies, or COVID. They can just walk right into a community pharmacy and get taken care of. They don't have to wait around for a week or a month to get in to see their primary care provider. The primary
Right.
care providers still win because they're still managing the care plan of that patient and they're getting paid for that for managing that care plan. So it's like mailbox money to the doctor because he's not having to even see the patient. He has to supervise it, but he doesn't have to
Right.
see them. It also improves their quality measurement scores, which allows them to get higher reimbursements for when they do see the patients that they see. But then the pharmacy wins in this scenario too, because they're the place of service. So approximately
Right.
65% of all the bill charges stay with the community pharmacy. So we really believe it's going to be the lifeblood that community
Right.
pharmacies need to survive.
Nice. Yeah, that sounds great. Um, how many of like I've seen more and more, at least to my, I've been more aware of compounding pharmacies, right? Some of those more bespoke prescriptions and stuff. Are those all community based or majority?
They are. Yeah, most of them
Okay.
are all independently owned and a really tremendous business to be in in community pharmacy because they usually don't accept insurance. It's cash pay. They know how, bad the PBMs are, and so they've
Right.
gone to a cash pay model and are creating custom medications specific to that patient's needs. So a really great business model. We've got some really great compounding partners here in and around Phoenix and the entire state. But yeah, it's a uh, great business model. And again, probably their number one benefit is that they're bypassing the PBMs all on their own. Now, it does make it a little harder for somebody on like Medicare, right, to
Right.
use them because they're on a fixed income. But quite often, the medications that they can provide, if it's a typical maintenance medication, it's going to end up not costing the patient anymore because it's approximately the same as their copay. Um, as whatever they would have to pay on their insurance to get a medication. That's basically the cash price of what they could get it for from a compounding pharmacy.
Okay.
Which
Okay.
is another interesting point, Tim, when you look at making changes in and transparency and trying to help mitigate some of the problems with the middleman.
Yeah.
It was quite recent that PBM reform actually took place right here, and we were one of the states that started it. So Arizona and Florida were the two states that first pushed this change in the law for PBMs. They used to have gag clauses in their contracts, meaning that the community pharmacy couldn't tell the patient that
Why
their
they're
cash price was less than their copay.
right, right,
And Arizona and Florida were the first two states to pass a law that removed those gag clauses, and then a bipartisan law was passed nationally. And that wasn't like the 1950s when that got removed. That was like
2010.
2018 or something
Oh,
like that. It
okay.
was
Yeah.
fairly recent that we
Wow.
finally got those gag clauses removed out
Yeah.
of
I
contracts.
remember hearing the difference. I was like, yeah, for all sorts of healthcare services, you're like my copay was more or than just
Yeah. Yeah. Think
cash.
about
It's
that.
crazy.
Your copay would say that you owed 37.50 for this medication, and the pharmacy would say, well, the cash price is only $10, man. I can
Right.
literally save them, have them pay a third of the price of what their copay is, but they couldn't say that back in the day. Well, now today they can tell you that.
Right. Or other like an X-ray or an MRI. I can go,
MRI,
oh,
yeah.
yeah, how much is it? Oh, it's $550. I'm like, okay, but if I just came in off the street with
Yep.
cash, you just, oh yeah, 250. I was like,
Yeah, no,
wow.
you nailed it exactly. It's literally about half of the cost on those bigger things like MRIs and X-rays. So it's always worth it
But it
if
doesn't go against your deductible.
it does not go against your deductible. And I'm like, screw the deductible. But yeah, I'm never going to reach my
Right.
deductible. But
Yeah,
let's go ahead
that's
and
not
pay
the
cash.
goal.
Yeah, yeah, exactly.
Right. Okay. Interesting. So, before we wrap up, I wanted to ask a little bit more about what Florida and Arizona were the sort of the first to sort of lobby against the gag repeal. Who was the driving force behind that? These are both retirement states. I'm wondering if it was some sort of like ARP or some sort of group that championed that movement.
Yeah, I know. Well, from our standpoint, it was working with the National Community Pharmacist Association. So we're
Hmm.
a corporate member with NCPA,
Okay.
and driving a lot of lobbying efforts
Okay.
through that national, Community Pharmacy Association. From the state wise, I'm not sure why if it just resonated with the leadership of those two states first, but our effort was through the National Community Pharmacist Association to get those gag orders removed.
Huh. Okay.
Yeah, we
Interesting.
we've been lobbying in the state for the rights for community pharmacies for a lot of years as ServRx, and one of the things that we really pushed back on was that changing of the ability for a physician to, have a point of care, a pharmacy or to dispense medications to their own patient,
Okay.
specifically in workers' comp, because you have one of our partners who co-founded ServRx he's retired now, but he was an anesthesiology pain doctor that was doing spine blocks because people were
Mhm.
so in so much pain. They would come in
Yep.
and he would block the pain, and the last thing that they wanted to do was go to, wait in line at a pharmacy to pick up any prescription they needed to get them by until the next time they could
Right.
come in for a pain block. So he had a very small formulary of anti-inflammatories and pain medications that he would dispense right directly to those patients so that they didn't have the hassle
Okay.
of going to another pharmacy.
Okay.
And that law, because it was
When was
bypassing
that
the
law
PBM.
passed?
This has been right around 2019, I believe.
Okay, right before
2019,
COVID. Okay.
right before COVID. Yeah.
Okay. Okay. My wife started doing more of those herself as spinal pain injections and other stuff after COVID. So
Yeah.
uh, didn't know the difference. Okay.
Yeah,
Interesting.
you can still do you can still do the procedures, right?
For sure.
The blocks, but you just couldn't dispense an
Right.
additional oral medications to get the patient through after
Right.
that. So,
Okay.
yeah.
Interesting. So you've worn a lot of hats, Breck. You've been in various aspects of this industry for a while. What do you wish you would have known sooner? To help drive success in this field.
Yeah, I look back at I would have made different choices back 20 years ago when the first grandfather of the industry that I started with back in 2003 was the very first third party payer for specifically for workers' comp. Until that company
Okay.
existed, pharmacies had to figure it out on their own. They either had to have the patient pay for the medication out of pocket and then give them a receipt to take back to their employer, or they would have to trust that employee or that patient that came in and go ahead and dispense the medication, then hope they could get reimbursed
Oh, right. Right.
from the employer. And so, that whole transition was a pretty interesting time. That's where I really learned the industry, but I would have done things differently because when that first grandfather company was acquired by a big health system and rolled up underneath its PBM, um, I would have done things a little different because I left and didn't leave on good terms, and that big PBM actually filed a TRO against me, a temporary restraining order, because I was the
Wow.
guy that sat down with all of the community pharmacy groups and did the business reviews, and they it basically was a gag clause to keep me silent so that I wouldn't go tell the industry that their 50, 60, $70 reimbursements were going to turn into $2 or $3, because that's exactly what they did. So I
Right.
would have done that differently.
Right. Interesting. Interesting. Okay, and now I'm thinking numbers again still real quick. What percentage, what are the different size companies that are self-insured right now that are good candidate clients for ServRx, right? The smaller ones are not self-insured, but the medium or bigger ones are?
Smaller ones can still be self-insured.
Sure.
We process claims for, Bob's Pizza Shack. They may only have 10
Okay.
employees or something like that, but obviously the bigger the company, the big organizations that are self-insured, or the big municipalities. City of Phoenix is
Okay.
self-insured. Somebody that has a lot of employees, we'll obviously be able to move the needle a lot, you know, larger for them than
Right.
if they just only have 10 or 12 employees.
Right. Because hopefully they're not having one employee hurt or something every month. That's
Right.
10% of their. Okay. Excellent. All right, Breck. Thank you very
Yeah.
much. Um, if people would like to connect with you or learn more, where can they go? What can they do?
Yeah, pretty easy. Just email me. It's my first name, Breck, Breck, at serve, SERV. There's no E on the end of that, just SERVRX.com.
All right. All right. Great stuff. Thank you. Thank you, everybody, for listening and watching. Thank you very much, Breck Rice, for joining me today. I very much appreciate you sharing your insights into the industry and having a big impact on things and continue to help the community pharmacy culture. Thank you.
Thank you. Appreciate being on.
Inspired by our guests? Visit phoenixprosperitypodcast.com/guest and join us on the show and share your success story with Tim. The spotlight awaits.